All, this is Dr. Mubeen Sayed from Drbeen.com. Welcome to one more show. So let's have our quick discussions. Doug said, who tagged like before chatting? Yes. So welcome everyone. Carolyn, you're first. Diaz, you're second. Drbeen, hello. Christy, hello. Hi. Doug, hello. Texas, hello. DDS, three-way tie. Yes. Skyfrog, hello. I was reading your messages on Discord about your flying. I love it. Carlos, hello. Paula, hello. Simple Garden, howdy. Doug, who tagged like, yes, thank you. And Carolyn, hello. And then K Molier 504. I'm so needing to hear more from the mRNA doctor before taking on any of these. So are you saying that you want to hear more about the messenger RNA vaccines, or from the doctor, messenger RNA, the doctor who claims that he invented the messenger RNA drugs in 1988? Sigrid, hello. I wonder if spike stabilization reduces the number of T cell epitopes. So let's look at it. That's an interesting point. So let's say, let me actually close this one so I can. So what you're saying is that if we have a spike protein here, and let's say this is S1, this is receptor binding domain, this is S2 with the fusion protein areas. And in the beginning of the spike protein, they have changed 2 amino acids. Now, if they've changed 2 amino acids, just like the virus itself, who can change its own amino acids as well and cause mutations. So there are 2 amino acid based mutations, which means that there is going to be some reduction for the original virus, meaning our body is going to produce antibodies, maybe against this part as well, in an epitope. Now, when the actual virus comes in, this part will not be matching those antibodies or those T cells that were memory for this part. If they were, they will not bind to this one, and so the epitope will reduce. So you are correct in saying that there is a difference from the virus for 2 amino acids. Is this a very large difference? No, but yes, you're correct. In general, there is a difference. Closet Picker says, hello all, hello back to you. James, hi Dr. Bean, Luffy and Cool Bean, some C Bean, and hello back to you as well. So Luffy is still here. He's still sitting there. Phil, how are you? Welcome. Sorry. Okay, so Skyfrog says, are the multiple proteins per nanolipid particle identical or varied to be more effective? So I'll talk about that in a second. Let me very quickly talk about some of the coming days' activities. This Wednesday, I will be participating in FLCCC's talk because I think we are revealing the long haul protocol. I don't want to steal your thunder. Imagine you didn't hear it from me. So in that discussion, I am invited as well as a guest, so I'll be there. So this Wednesday, the talk is my time, 4 o'clock, and hopefully it will be over by 6 and we will do our discussion afterwards. But it is possible that it might go over, or I might need 10-15 minutes break. So number one, this Wednesday, there may be a late talk or no talk if it became too late. I hope it is not too late, because I hope 1 or 2 hours is sufficient. That's one. Second, this Thursday is the plan to have Dr. Eli Schwartz with us from Israel. If he joins us, that will be morning at 11, because that time will be 9 p.m. in Israel. So that is kind of pushing it forward from there is inconvenient. So this Thursday, if the time becomes approved so my executive assistant is working with his team, then this Thursday, discussion will be at 11 a.m. Pacific time. Then we are going to have Dr. Drbeen, who is an emergency medical doctor here in the US. He will be with us. He's the one with whom I had a chat, which was taken down immediately by YouTube or Facebook as well, I believe. So that would be an interesting talk again. Then we would have Steve Kirsch as well. I have requested Dr. Tess Laurie. She has talked about halting the vaccines. So I have requested her if she can come in and discuss with the cool beans that what are the things that she's seen that has brought her to a point to say, you know what, vaccines should be stopped, paused, and the adverse effect looked at. There are a couple of more doctors that we are working to get on the show. So I thought I would just quickly discuss this. Now let's go back to Skyfrog. Are the multiple proteins per nanolipid particle identical or varied to be more effective? So I believe, again, they have not given too much yet, but what I have read so far, from that point of view, the only change that they have done is this part. The remaining part is the same. And then the lipid itself, the nanoparticle, is actually just a core of the protein. I made it incorrect though. So let's say this is the particle core. It's not really a particle. What happens is that the spike proteins are bound to each other like this. And they make a configuration which looks like a particle. And the size of this configuration is very similar to that of the actual virus. So this is the nanoparticle in their area. So going back to your question, proteins per nanolipid particle, identical or varied to be more effective. So this is the only change. They are identical so that the antibodies are produced against the spike protein of the virus. There is one change to stabilize them so that they always stay closed and they do not open up, because then our antibodies will be, so let's say if the spike protein has opened up in their vaccine, the spike protein looks like, let's say, this way. And now the antibodies are formed against the open areas. Then these antibodies can only attack the spike protein when it is open. But in the case of the actual virus, when the spike proteins are open, at that time, the virus is actually bound to the cell. So what would antibody do? The virus is already stuck to the cell. That is why. And I'm sure that other vaccines also have this stabilization. Grace says, isn't the spike protein going to cause more problems with natural COVID than with a vaccine containing spikes? Correct. So now I think we should talk about this, because many folks have been very upset with me that somehow I am dismissing the role of spike proteins. So let's talk about that for a second. Yes, virus has the spike proteins as well. And then, yes, virus causes death too. So the problem is not just the spike protein. Spike protein is a part. We know that, number one, spike protein is useful for the virus to bind to the cells and then to enter the cell. So for infectivity, spike protein is important. And with the newer variants, that affinity to bind with the AS2 is increasing. So spike protein is an important weapon for the virus. The second part is that there are studies that say that the spike protein alone, when it binds to, let's say, AS2, it causes, and I did this study and discussion of it. So let's say this is the cell. When spike protein alone binds with this part of the AS2, it causes internal changes in the cell, and the cell stops making nitric oxide. So if it is an endothelial cell, the blood vessel cannot vasoactivate anymore, meaning it cannot dilate anymore. So that would cause vasoconstriction, that would cause reduction in the blood flow. There could be local inflammation as a result of this as well, which would mean immune cells would come in here, they would start killing the cells here. That can cause blood vascular damage, that can cause tissue damage. And then, of course, a normal behavior of spike protein or the virus will be, so this is going to be common for both, is going to be to cause immune system to respond. So that is the intended behavior in case of a vaccine. So now if I go back to your question, isn't the spike protein going to cause more problems with natural COVID than with the vaccine containing spikes? And that is correct. And the way I would look at this comment that you made or question is the following. For a natural infection, the virus is going to get into the cell, come out in millions, then get into the next cell, come out, and not just one cell, because now the numbers are more. It's going to get into many cells and come out in millions, and then just keep doing this and cause lots of destruction. And then the virus is going to continue to go into other tissues and just keep causing problems. Spike protein, now I want to keep this one piece separate, that will this spike protein enter the bloodstream, go to various tissues and cause damage, versus will this spike protein enter a cell and what would happen? So first of all, this spike protein and this little particle will not be able to enter the cell just like the virus does. It can bind to the ACE2. Now the question that is in my mind is that if they have stabilized the spike protein in a pre-fusion state, that is like if you put a straight jacket on someone and they cannot move their hand anymore, they cannot open their hands anymore, or put a glove that can bind the hand. So if the spike protein cannot open, will it bind at all to ACE2 or other parts of the cell? That's one curiosity. I do not have the answer to that. The second part is, will it enter the blood system or other systems? And what are the ways for it to do that? It is big enough particle that it cannot just simply enter the bloodstream. So if it has to go to the bloodstream, the pathway will be for it to go through lymphatic system, because lymphatic channels are bigger channels. So it has to enter and go to the lymph. From there, it has to enter the bloodstream. From there, it has to go to heart, and from there, it would go to the other places. Is it possible that some of this would break down over here? Possibly not. But because auto breakdown is not going to be easy, so let's say this is the structure. The question would stay, and that is, will the immune system pick up this thing before? So that means the neutrophils, macrophages, dendritic cells, will they eat up this particle and process it and present it and start the immune system responses here, or somehow these spike proteins would just take off? That is the question. I can answer you from a mechanism point of view that it will be very difficult for this spike protein particle to end up in the blood system or to end up here in the lymphatic, and I'll give you the reason for why. So, and we have done this talk before too. So again, if you don't believe me, just look at, this is immunology 101. So it's not a science that for which I have to provide studies. You can just look at any of the books for immunology. What happens is when there is a foreign antigen, that antigen would trigger the local immune cells that, remember, so there are PRRs, pattern recognition receptors. There are Toll-like receptors, TLRs. These are present on macrophages and dendritic cells. Neutrophils can just generally eat up these things as well. So these cells would eat up or phagocytose these particles. Then they would fuse the phagosome with the lysosome, break down the particles, present them on the surface. We have done this before. MHC1 loading can occur, MHC2 loading can occur. In the case of this vaccine, what is interesting and fascinating for me is that ideally, from a mechanism point of view, this particle cannot enter a regular cell. Because in the other cases, for example, messenger RNA vaccine has a lipid particle that is used as a vehicle to bring the mRNA inside the cell. Once the mRNA is inside the cell, it is difficult for the mRNA to get out of the cell because it is a messenger RNA. It cannot just cross the cell membrane. If it could, then the vaccine did not need to have a lipid nanoparticle, because then mRNA would just diffuse across the cell membranes. That doesn't happen. So once the messenger RNA is in the cell, we're talking about Moderna, Pfizer-like vaccines, then the vaccine would produce the spike protein inside the cell, which would then be presented, broken down, presented on the surface. And as you're seeing some studies that have a conjecture that these would even be secreted out. I don't agree with that, but let's say that that is a mechanism. So that's what's happening with messenger RNA vaccines. Now, can this particle, this one, the Novavax particle, enter a cell and do these things? No. So presentation on the MHC1 will be difficult. Now, macrophage can present it on MHC1 and MHC2, but it would present it on MHC2 because anything that is eaten up by the macrophage is then presented usually on MHC2. Anything that is produced inside the cell and it is foreign material, it is usually presented on MHC1. So that actually is a protection. So for example, if you say, I do not want a spike protein to be produced inside of my cell, then this spike protein will not be produced inside of the cell. It will not go inside the cell. And if it is sitting outside, it would be picked up by the macrophages, dendritic cells, and others and presented and broken it. So that's actually a good thing of this vaccine. And I believe we do not have any other vaccine of this type. So let's think about it. Messenger RNA, that would go into the cell. Adenovirus based, that is the AstraZeneca, CanSino, Sputnik, Johnson & Johnson, they would go into the cell as well. Inactivated virus would also not generally go in the cell because it is inactivated. However, because it has the whole spike protein and the virus attached, it is possible that instead of phagocytosing, it might be pulled into the cell by the spike protein's binding. Here we have a pre-fusion stabilized spike protein. The virus will not have a pre-fusion stabilized spike protein. So it is possible that the virus, inactivated virus vaccine, might end up in a cell as well. This one seems to be not going to do that. So that means only immune system would pick it up and process it and work with it. So are we then concerned about this one getting into the cells and going into the body and doing those things? I don't have that concern because of the way this structure, this mechanism is. So let's say it did escape this immune system, local immune system, and it did go into the lymph and ended up here in the lymph node. Inside the lymph node are also lots of macrophages and dendritic cells and follicular dendritic cell and other cells. It's actually like army's barrack. So for this thing to enter in an army's barrack is going to be a problem. So it is going to be picked up over there. Let's say that even if it is not picked up there, that means then it would enter the blood system. Now, if it is in the blood system, we once again have an endothelial cell. Let's say it is in the blood vessel, and this is the endothelial cell in the blood vessel. And here is this little, I shouldn't make it particle-like. Here is this little thing, virus-sized particle with spike proteins, and that's all. Now, will it bind to the ACE2 here? Again, I do not know from a research point of view. When the research would occur, we'll know. From a mechanism point of view, it is going to be difficult for it to bind here. Why? Because the blood is running fast. Blood is flowing fast. And this is not a problem here in general. Whenever the blood is flowing fast, many of the molecules do not find a way to enter or until they are able to diffuse. This is a big enough particle that it cannot just diffuse. So it will have to figure out some way to bind. So will there be a chance of inflammation and vasculitis? Difficult. One way the vasculitis could occur. And now, so we're going to create another provision. And that is this. Bring in the spike protein in the blood for whichever way, let it escape from the local site, go into the lymphatic system, escape from there as well, come out in the blood. And now at the same time, have the immune system become ready. So we know that the immune system, so let's say there are more spike proteins and the immune system is becoming active as well. And finally, we have the B cells that have become active. These B cells are making antibodies. Those antibodies, bring them over and attach them to the spike protein. Now we have antibody antigen complex that complex can settle wherever it would get attached. Remember that the antibody would have a receptor on macrophages, for the FC side, on the mast cell, many cells have them. So this combination, if that settles or binds, that can cause local inflammation. How possible is that? Vasculitis can occur when there are antigen antibody complexes settling on it. So in this case, what are the provisions to give to this particle to be able to do this? One, we have to somehow allow it to enter a blood vessel. Secondly, we have to have the antibodies present in the vascular system as well. Thirdly, we should have them combined. Fourthly, we should have them settle down on the surface and then get trapped there and then cause local damage. So all of those have to occur for the spike protein to cause damage. Now, once inside the blood system, can it get out? So again, for it to get out, it still would need some processing. Usually such particles that are big enough to escape the vascular system and they have somehow entered it, usually these guys, these bigger particles, are cleared out in spleen and in liver. So there are immune system cells that are sitting in spleen, for example. Spleen have sinusoids. So the medicals here would know that spleen has, like jail, and jails have these bars. Spleen's structure is made up of the sinusoid where there are bars in it which are narrow. So imagine these blue ones are the bars, and the whatever substance is moving around in the blood, it has to kind of slip out of these bars. Even blood cells have to do that as well. And this is how we actually remove red blood cells. Those red blood cells that have become clunky and have lost their flexibility, or the sickle cells, they get trapped here. And now next to the bars are sitting macrophages. So these macrophages, their job is to do what? Their job is to pick up things that get stuck here in this filter. So imagine that spike protein particle is now passing through the system, and the particle is large enough that it got stuck here. If it got stuck here, although it is a virus size particle, I don't think it would get stuck. But if it gets stuck over here, the macrophages here are going to eat it up and clear it out. So that is one way the pathogen or this spike protein will be cleared out. Otherwise, it would have to settle down, maybe here in spleen or in liver, and then over there macrophages would have to clean it up. So I hope Grace, that answers this question. And thank you very much for the cat opening the door. Somebody sent it to me. Was it you who sent it to me? Luffy and Kyrie do the same thing. Nina says, Dr. Bean, J&J vaccine, thyroid problems, anyone else? So I haven't yet heard of the thyroid issues with the J&J. But if we think about it, just like cardiac inflammatory outcome or like clotting outcome, it is possible that there are some antibodies that are produced which are then targeting or cross-reacting with the thyroid gland. So the question, remember we talked about it before, that have we done the scans of the thyroid to understand, is it the functioning of the thyroid that is incorrect, or the stimulating hormone is not present there, or iodine is not present there, or inflammation has occurred, and is that antibody based or what? So some more data is needed. I haven't yet seen others to have it. Jack says J&J strokes and clots. So adenovirus based vaccines are now known. We started with no association to association, and now I believe there is a causation that we are seeing that there can be clotting started. Once the clotting is started, clots can get stuck in so many places and then strokes can occur. Neeli Das says, can you please discuss about things missed in last session about Pfizer JP and biodistribution study, that is messenger RNA encoding luciferase, radiance observation on page 6, reflecting spike distribution. So I am going to talk about this tomorrow. The reason for that is that I want to make sure that I look at those pieces as well. Some folks have said that I deliberately missed those. So there are folks who said, I have become a shill for big pharma and I'm protecting them. I don't think they need my protection, number one. Number two, some others said that I have become too afraid to be able to correctly present much. And honestly, people have sent me death threats or said me that they'll get me in jail. And most of those folks are from anti-vax groups, not from the vaccine group. So if I wanted to feel more safe, I would have started doing anti-vax discussions, and that would make me feel safe because most of the threats I get are from this group. So I don't get threats from the vaccine groups or vaccine companies who are saying that if you didn't do it, somehow we'll do something. That's just absurd. But I know that those folks were just trying to instigate me to say, you are a coward, otherwise you should talk against it. So I'm going to look a little more on that document to understand it even more, and then we'll talk about it. So Neely, I think, wait till one more day. Rondon says, which vaccine do we have the least risk? AstraZeneca, J&J, clotting, myocarditis, Novavax. Very good question. And I'm going to quickly create a chart here for ourselves, all of us looking at it together. So let's say we say, instead of a specific vaccine name, I'm going to say the platform, messenger RNA, adenovirus. Now we're seeing subprotein, inactivated virus. There are more theoretical vaccines like the super vaccines, but they're not out in production. These are the ones that are out. Subprotein will be out hopefully soon. So let's look at what are the basic differences in them and who should and should not take them. So look, we know that J&J, which is here in the adeno, we know that J&J, and this is from the J&J's own FDA briefing document. This is from their own trial document, that above the 60 years of age, J&J's efficacy is about 40%. So J&J isn't much useful for folks who are 60 years or 65 years and above. This age, I'm not exactly sure, was it 65 cutoff or 60, but I'm sure that the vaccine efficacy was low. Why am I sure? Because when I looked at that document and looked at that part in the table, I said, oh man, this is below the effective range. So one problem, so this group is out for J&J. If I can write here, greater than 60 years of age, J&J does not seem to be useful, one. Secondly, we know that under 50 years in women, there is women under 50, they have a propensity of the clotting. So that means this is out for them. And I'm seeing this more in Europe now. They suffered more as well with this kind of a vaccine, AstraZeneca. So I'm going to put this J&J plus. This is J&J specific. This is AstraZeneca and J&J, and probably other as well. Although nowadays I'm seeing statements from Sputnik saying that our vaccine is structured, the DNA is structured in a way that it would not create antibody structures that might cross-react and cause this. So we are different. I haven't seen it, so they may be different, they may not be. So AstraZeneca and J&J both, for women under the age of 50 years, are not correct. Or if they have to be given, then they should be given with medical supervision. I like Europe at this time that they're trying to move away women younger than 50 to more messenger RNA type vaccines. Now, if we look at the messenger RNA vaccines, did I miss anything on the, yes, so I missed, if we go to the messenger RNA vaccines, the most common thing that we've heard, other than the allergic reactions, and once again, it's not necessary that somebody has to have allergic reaction to develop the allergic reaction, but general guidance has been that anyone who has had anaphylaxis in the past or who have had EpiPen, they should be careful, they should talk, they should approach this whole thing in a more deliberate and thought out way. So allergies or allergic reaction is one possibility. The second one is the cardiac inflammation. Now, this cardiac inflammation, allergic reaction, I can't say the gender or the age group. Usually, women have more allergies than men. So maybe messenger RNA-based vaccines slightly more careful with the women, but I don't think that there are, meaning it can be managed. EpiPens are there, it can be managed. Cardiac inflammation. So the cardiac inflammation that is observed under 30 years of age, they say that it is observed more in men or boys than women, but in Israel, the one person died was male and one woman died as well. So the death occurred equally in both, even when the risk factor was less for women than men. So I would not give messenger RNA-like vaccines to this group unless there is a proper protocol to make sure that if inflammation, heart inflammation is possible, then they are already on some protection. Then if we go here to inactivated virus. Inactivated virus, in theory, people say that that would cause ADE. And it is so interesting that the folks who are upset about inactivated viruses, maybe for political reason that it comes from some countries they don't want to, they talk about ADE over there. And then the folks who are upset about these are also talking about ADE. So ADE still remains a theoretical mechanism. There are some studies that are saying we are seeing ADE, still needs to be proved. So inactivated virus, in my opinion, it is a good vaccine in theory. I do not know China's vaccines behavior or India's vaccines behavior and the data and the safety data. I just don't have that data. But generally, from a mechanism point of view, giving a whole virus that then allows antibodies to be produced in a cocktail to the parts more than the spike is a good thing. Once again, going back to the folks who are upset about vaccines, they say, well, there will be lots of binding antibodies that will be created and that would cause issues. There is a study that I discussed. There are folks who say that spike protein causes a greater ratio of binding to neutralizing antibodies, so that would cause this as well. So I think we don't have good science there. We seem to have more biased science there. And it is interesting that even when I am talking about these things, people call me biased as well. So my biases are open. I do not have a problem with the vaccines in general. So there are some vaccine concerns, and I put them in the right place to say this is the concern and this is what should be done, instead of saying all vaccines are bad. So inactivated vaccines, I do not have enough data to say it is good or bad. Mechanistically, it is actually good. Now, subprotein vaccine, the data that is missing in the today's discussion, in the press release, we still do not know, for example, tinnitus. We do not know the thrombocytopenic purpura or clotting. We do not know the risk of strokes. We do not know allergic reactions. That is yet not known. It didn't happen. We don't know. It happened. We do not know. So this would still need to be brought in. If there is going to be an issue, that is going to be because of the adjuvant more than the spike protein itself, because we know what spike protein does. And the spike protein doesn't have an RDRP, or doesn't have a 3-chymotrypsin-like enzyme, or doesn't have enzymes to block the importin alphas and betas. Spike protein cannot do that. And then in case of this Novavax, I believe the spike protein cannot even enter the cell because it is a big blob attached to many, many other spike proteins. So it will have to be phagocytosed. It would have to activate the immune system. So in theory, still, to me, this looks a good vaccine. So now, would there be any group that will have a contraindication to this one? don't have that data yet. For example, it is possible that this would cause clotting as well. Why? If the clotting is because of not the adenovirus, but because of the DNA in there, and that DNA causing some sort of a cross reactivity, then we have a protein piece here. That protein piece can technically cause cross reactivity as well. So can clotting occur? Yes. Will it occur? I think no. But virus itself can cause clotting too. So that is one possibility. Can the molecular mimicry for the cardiac inflammation occur? Yes. Will it happen? Don't know. So this is what I have so far for which people and what vaccine. So what should happen is then the questions to be answered should become, okay, so what do folks greater than 60 years of age do? So in my opinion, greater than 60 years of age, messenger RNA vaccines are better, or Novavax would have been better. We need more data on the Novavax. Why messenger RNA vaccines are better? Because the cardiac inflammation seen with the messenger RNAs are actually at the younger ages. Then women who are 50 years of age or less, to me, it seems like adenovirus-based vaccine is a no-no. And I would give, so this is I think I do a good thing by doing a disclosure. People actually then say that, hey, you did it by yourself and now you're telling us. My wife is under 50 and she got Johnson & Johnson. So that was, and she had the side effects, although not the severe ones, but she did. She still has some of the side effects. So I feel that women under 50 years of age, adenovirus-based vaccines are not very healthy for them. There are more risks with that. So what should the women do who are that age? Messenger RNA-based vaccine, which is the age level which is more safe. So 30 to 50 messenger RNA, or you can say greater than 30 messenger RNA for women seems to be a better option. Now, what do we do below 30 years of age for women? Adenovirus-based cause issue, messenger RNA-based cause issue. Maybe the subprotein will not cause it, but I do not know that data yet. And I also do not have data for inactivated virus. So there is a risk for women under the age of 30. In case of messenger RNA, the risk is of inflammation. In case of adenovirus-based RNA, there is a risk of clotting. And that is true for men as well, but mostly for the women. The inflammation under 30 years of age, men, I feel that adenovirus is better because the messenger RNA-based vaccine cause inflammation, cardiac inflammation. So this is how a weaving of the, or navigation of the decision can be done. Dr. Amir Hashmi says, can anybody take vaccine if they had cardiac issues? So I have done this discussion before as well. In Netherlands, there were a number of folks who died after taking vaccine because their body could not handle the stress that vaccine added in terms of nausea, diarrhea, vomiting, which then put stress on their cardiovascular system to compensate with a higher heart rate, and more blood pressure was needed. And the body could not take it. They were too frail for that. So to answer your question, Dr. Hashmi, the cardiac issue generally is fine. That is not a contraindication for the vaccine. But think about it. Here we know that messenger RNA vaccine under 30 years of age could cause cardiac issues. Now, generally under 30 years of age, youngsters don't have heart issues. There are exceptions, there are comorbidities, but mostly they don't. So in that case, generally the vaccine should be okay. Now, if we go above 50 or 60 and people start having cardiac issues, then you add a vaccine that may cause nausea, vomiting, diarrhea, low blood pressure, that could become an issue for the heart. So generally, just making a broad statement to say that cardiac issue patients should take a vaccine or not is not possible. It really depends age, what is the issue, and then what can a vaccine do to stressing that heart, and then which vaccine will work better. Okay. So Michael Stalwart says, any thoughts on why hydroxychloroquine, artemisia, ANWA, and zinc helped with my long-haul heart palpitations better than ivermectin? That is interesting. So ivermectin actually does not have a cardiac effect. Hydroxy and zinc do. They actually are supposed to increase the QT interval, which will then cause torsades or causing arrhythmias, because it kind of slows down the heart during that interval, and that can then kick the heart into an arrhythmia. So if you had palpitations, it is possible that hydroxy would actually calm down the palpitations. And zinc is just a partner with hydroxy. So Anne says, my father took the Moderna vaccine and has an ICD implanted. And I hope that the next part of the sentence is that he's doing fine. One thing I forgot to mention with the Novavax vaccine, the absolute risk reduction. So let me just do that part as well, because I had actually, in the description, I have done that math, because folks say that, hey, that data is not given. So look, here is the data just very quickly. I'm going to look at the math I've already done here. So about 29,960, I kind of consider it to be 30,000, but 29,960. Out of them, 19,973 had vaccine, and then about 9,986 had placebo. So 20,000 on the vaccine and 10,000 on the placebo. You can see that in general. Cases were total 77, and then there were 14 cases here, and there were 63 cases here. Now, for the risk reduction, what we have to do is first we have to take the percentages of these. So the percentages were, this would be called the experiment event rate, EER, or intervention event rate, and that is the cases in the intervention or the vaccine. So this was, what you do is you do 1,400 divided by 19,973. You take that percentage, and that percentage is 0.07%. And then if you do the same thing here, the EER here was 0.63%. So get ready for the risk reduction. So what we are saying is that the baseline placebo would have 0.63% chances of the infection. That means about 150 out of 150 people, one will get infected. And when the vaccine is given, and you take another 100 people who are vaccinated now, you would see that the risk to them is 0. So I'm going to make a tiny bar here. 0.07% is the risk left. So of course, it's not to scale. So what is the risk reduction? This much of the risk is reduced. Absolute risk is reduced this much. So how do we calculate that? We subtract them. So we do 0.63 minus 0.07, and that will be, and these are percentages, that will be 0.7. No, so that is the sum. So if I subtract them, that would be 0.56%. So this here is 0.56% reduction. So this does not mean that the reduction is sub 1. This simply means that the overall infectivity was 0.63. And out of 0.63, instead of 0.63, after the vaccine or whatever intervention is, here we're talking about the vaccine, the new risk is 0.07, that is 0.56 absolute risk reduced. Now, in terms of efficacy, meaning what is the comparison of these two values to each other, how much of the risk has actually been reduced, that is 90%. And how do you do that? So first of all, you get the risk reduction. Risk reduction will become, or the RR, that will be the what is that? Relative. So the relative risk, not the risk reduction, relative risk will become 0.07, which is the vaccinated side, divided by 0.63, which is the placebo side. You take that number, and then 1 minus relative risk is the risk reduction or relative risk reduction. So that would come to be about 89%. And then efficacy is really what we know, ratio of this. What does this actually mean, this whole thing, or these numbers with the vaccines? What do they mean? What they mean is the following. And I think this is what is interesting, to say that if we had placebo, out of 158 people, one gets infected. If we had vaccinated group, then you need 1,428 people for one person to get infected. That is the difference between them. This difference is 90% efficacy. So I wanted to make sure that absolute risk reduction, I know that some folks will just look at this number, and say, well, that is not even 1% improvement. But here's the deal. The improvement is from 0.63 to 0.07. That is a 90% improvement. The absolute improvement is 0.56% because the baseline is very low. So I hope that that answers, or that not answers, but adds some more data. Okay, so let's see. Mr. J says, after mild COVID, I got 1.5 milligram dexamethasone, 1.5 milligram dexamethasone for 10 days, and my congestion went away. It returned after the 10 days and won't go away now. Is that a long haul symptom? Yes, it is. And congestion did you have the congestion before from the COVID? Sometimes giving steroid suppresses the immune system, and some other opportunistic things can pop up as well, although low dose steroid doesn't do it. So I tend to say yes, but without knowing more in history, I should not diagnose like this. So Mr. J, are you on the Discord? Can we have a separate chat to figure it out? Generally, if this was for me, I would say I am a long hauler. Jody says, I don't see CDC stopping vaccination for kids. People are too scared of exposure. Yeah, so Jody, in case of Novavax as well, excuse me, you just saw that kids 20 years of age and above, 2,400 something, are now participating in it. So this is a good question. Jennifer says, how long will bamlanivimab, monoclonal antibody, last in the body, and how is it different from the vaccine, and what does it do in the body? Thank you for your time. So Jennifer, very good question. Let me just very quickly see if I can draw this. In an acute, so let's say this is a person, and the person has acute infection, active infection. So that person has the virus, and the virus contains the virus body and the spike proteins. And if they're becoming severe, that means that their immune system is either not able to take care of the virus, or the immune system, while taking care of the virus, is overreacting and causing too much of cytokines, and that is causing problem that the person is in trouble. So we want the virus to get out quickly. Now, first thing, so you have many questions here. I'm going to try to answer all those one by one. So first thing, bamlanivimab-like products are useful when the virus is there because these are targeted to the virus. Imagine that these are policemen who are trained to uh, to pick only the thieves who are trying to break doors. So they would not say anything to anybody else. So here there is a virus, it is trying to break doors, and the antibody is directed against it. That means if a patient is in a state where they have entered the cytokine storm state, usually 7th, 8th day and onwards, and there is no more virus there. This is like a virus came in and set fire to the house, or a thief came in, set fire to the house, and thief ran away. Now, if you send the policeman to say, please go in the house and arrest the thief, there is no thief there, and the policeman would get injured too. Now we need to send in the fire brigades, or the the folks who would fight fire. So in the cytokine stage, when the body is on fire now and the virus is not there, then bamlanivimab will not be needed. So the first thing, it is needed during the active infection. Second part, what does it do? What it does is, it is an antibody. It is a monoclonal antibody, usually it is geared against a spike protein. So when the virus is present, bamlanivimab will be a pre-made spike protein, antibody. We are suspecting that the person is not able to make good enough number of antibodies or fast enough. Maybe the person is, their cells are old, or the person is immunosuppressed, or person just did not handle the system very well, and that can happen to youngsters too. Or they are diabetic, or they have leukemia, or they have cancers, or they are on chemotherapy, or they have steroid therapies. Somehow their immune system is not working correctly, and we want to send the policemen from outside. So these are pre-made antibodies that are made outside of a person, and then they are sent in, that would go and mop up the virus. Usually these antibodies can live without getting destroyed for 3 weeks. Although these antibodies are treated a little more, and they can live longer than three weeks, for example, 1 month, 1.5 months. I do not know exactly bamlanivimab's biological life is how long, because they modify these antibodies in a way that these antibodies are a little more stable, and they can be in there for longer time. So now, function in the body, when is it necessary? How is it different from vaccine? So vaccine is not, so this is called passive vaccination. This is actually a passive vaccine, that we are sending in something that would work. You've sent the antibodies, which are measured quantity. You sent, let's say, 1 billion policemen, and that's it. You don't have more policemen. You just send that much. In case of a vaccine, what will happen is that the vaccine would go in and train the immune system cells to learn how to create more antibodies and continue to create more antibodies. And so when the virus is present, they would just keep making antibodies and make and make and make till they either kill the person or take care of the virus. In case of vaccines, usually take care of the virus. In case of actual infection, possibility of killing a person too. Although vaccines have adverse effects too. So this is the difference between them. A vaccine trains the immune system, makes it independent. And so, for example, I'm a healthcare worker, and I have to go to a hospital, and I have to face patients who may give me COVID every day. If you give me bamlanivimab, it would protect me for a certain period of time, let's say 4 weeks, 6 weeks. After that, I still need something once more, because bamlanivimab or those policemen are gone. But if you train my immune system, either by an actual infection before or by a vaccine, then whenever the virus would appear, our immune system will wake up, make the antibodies, and attack the virus at that time. Straight says, Novavax has same adjuvant as Shingrix, Novavax. So they say that we have Matrix-M. Is that the same as this one? Vaccine tested in more than 3,000 patients in 60 clinical trials. It is a component of the Shingrix vaccine. Very nice. Good. They are very proud of it. They actually have, if I go to their site, Novavax has, if you go to their science, And I don't have any problem for them being proud of it. I'm just kind of showing. So this is their matrix M adjuvant technology. And if you go here, they have how this adjuvant is made. So if you see here, matrix M is composed of 40 nanometer particles based on saponin extracted from the Quillaja saponaria molina bark together with cholesterol and phospholipids. And here they're saying what it does and so on. So they feel that this is a great technology. So yes, they have it. So Stratilize, thank you. Linda says, are you saying that the natural immune system does not know how to work? It has to be taught how to recognize what chip trained it. So seems like some rhetorical questions. In the majority of the people with healthy immune system, their immune system knows what to do. And that is how many people who get COVID or other infections, they are able to come out of those in a healthy way. But then there are some folks whose immune system will overreact. And I'll give you many examples of overreaction, not just the COVID. Allergies are an example of overreaction of the immune system, or not a correct way of behaving for the immune system. There are rheumatic diseases, there are autoimmune diseases where the immune system doesn't know how to behave correctly. There can be joint pains, there can be thyroid destruction, there can be other tissue destructions. These are autoimmune diseases. That is a failure of the immune system to work correctly. Then in case of COVID as well, we are seeing that in some people, and there are percentages, we know the percentages, for example, 19% of the people overall globally, and various communities and their populations and their socioeconomic statuses and their interactions and their hygienes, their behaviors, all of that changes this. But globally, 19% of the people who get infected end up in a hospital because their immune system did not work correctly. And then about 5% end up in ICU because their immune system did not work correctly. Now, not working correctly doesn't mean did not work. Sometimes not working correctly means overworked, became more mad than it should, created a cytokine storm. And then we know that 2 to 3% will die as well because of the immune system's responses, not because of the virus. There can be virus destruction as well, but most of the destruction we are seeing is the immune system issues. So now if I go back to your question, are you saying that the natural immune system does not know how to work? It knows how to work. It just does not know, in some people, how to correctly work. It has to be taught how to recognize what chip trained it. So I do not understand this part of the question, that it has to be taught. Immune system cannot be taught by chips. It just does not understand the chips. So because of that, I don't think there is a chip that can go and tell it anything. But an antigen, a foreign material, is not liked by our body. Our bodies don't like it. So when you inject a foreign material in our body, our immune system trains itself to fight with that. And so when you give a vaccine, our immune system would train itself to fight with the vaccine or anything that looks like that vaccine in the future, which may be the actual virus. So immune system just gets irritated on the vaccine or the infection. So Cool Tune says, Dr. Mubeen, send pile of ivermectin. I'm in Canada, please. Can you please connect me with me on Discord? I'll see if I can connect you with some doctors. Antonio Simon says, people have headaches after AstraZeneca for weeks. On forums and Reddit, I'm 30 years male on first jab, 3 weeks still headache. CT and blood is okay, no clots. Can AstraZeneca be affecting our nervous system, or is it something else? So very important question. Actually, this morning, who was I speaking with? I was speaking with someone who also had headache. I totally forgot. who also had headaches after the vaccine. And they were so upset because those headaches were continuing for a long time. And not only headaches, some people developed tinnitus as well. So, Antonio, this is kind of a vaccine-caused side effect. Good news in case of infection long haul or vaccine long haul, that it actually continues to improve in majority of the cases. However, for this, the easiest thing to do to start supporting yourself is to do the neck massage and lymphatic massage and spinal cord movements. With that, light exercises, please don't do a lot of rigorous exercises. And then this Wednesday, we'll talk about the long haul protocols and how to use them. So there are some things that you and your doctor can do to get you out of this. I'm sorry to hear this. So Doug says that we all want Dr. Robert Malone. So I have asked Melissa to talk with Dr. Robert Malone. I want to just make sure that we all are aware. It is actually, what is this question? So Big Natty Brubs says, Brubs, is it fair to brand these messenger RNA adenovirus vector vaccine as gene therapy? So, first of all, what I have learned during this pandemic's discussions. So I was used to talking with medical students, with doctors, and had not presented generally. And what I've learned is that if somebody is going to believe something, then they're going to continue to believe it. And the reason for that is that there is some underlying pain or fear or concern that they are trying to justify by believing something. And if you ask them not to believe it, then that underlying concern does not have a foundation, and we don't like it. All of us humans do that. That is how our belief systems develop. So I don't want to have an argument, and I avoid these arguments. But this weekend, when I talked about this Pfizer vaccine discussion, there were many people who tried to once again curse me and yell at me and told me I'm a coward and told me that I'm this and I'm that. And all they wanted was for me to engage, and I didn't engage. Here, you want to call it a gene therapy. The definition of the gene therapy is to be able to give some. So there are two definitions now. There are giving genes, administering genes that would create a product. That is a gene therapy. Or administering something that goes in and changes our DNA's structure and fixes some gene. That is a gene therapy too. So going back here, administering, for example, messenger RNA, which will then is a genetic material which will help make something, for example, spike protein. So in some people's definition, this is a gene therapy because we sent in a gene to make this protein. This is an incorrect position, and this position is taken by doctors as well. So it's not that I'm saying that, hey, non-doctors are doing this. Doctors are calling this gene therapy as well. Look, for gene therapy to be a gene therapy, what that means is that inside the DNA, there has to be a gene. That gene has to open up, then it converted into messenger RNA, and then that is translated into a protein, and protein does its function. This is a normal process flow of a gene to function. In this therapy, there is no gene here, there is just messenger RNA, which is a result of expressing a gene. So this can be called a messenger RNA therapy. This can be called a genetic therapy. I do not think it can be called a gene therapy until we change the definition. Again, at the end of the day, we humans made these definitions. So we say, you know what? We want to include this as a gene therapy as well. And this piece of messenger RNA, we want to call it a gene. Fine. Then all the other definitions of gene will become incorrect. For example, a gene needs a DNA structure. A gene needs a promoter box in the beginning. That promoter box is something that would promote the opening of the gene. It has control boxes here as well that promotes either the closure of the gene or opening of the gene. Then the genes or the DNA has signaling systems that would come in and ask the gene to open up or close down and do stuff. So gene is like, imagine it is a chef at your home with the books it has, and you have to tell the chef what to do by various signals, and it would use your command and then open up the proper recipe and then use that recipe to send orders outside to say, do this. So it has controls and it has enzymes that work with the gene. There are enzymes that open the gene. There are enzymes that close the gene and so on. If you talk about a messenger RNA, there is no such thing for messenger RNA. When a gene works, we call it transcription. When a messenger RNA works with ribosome, we call it translation. They're different mechanisms. And so calling it gene therapy is kind of saying, I want to change medicine. I want to call medicine something else. And then it would become a headache of the medical folks to figure out that now the translation is also called transcription, and the transcription is not transcription anymore, and translation is not translation anymore. And so where is the gene and where is it? So the whole thing becomes a mess. A gene therapy will be something where you send in something that goes into the DNA, for example. And there are many children, unfortunately, who have genes that are not correctly built, or there are genetic defects. We all have some sort of genetic anomalies, but then there are folks who have so many that they show up. And then we try to send something that can go and fix this gene. So let's say here, this gene doesn't have this piece in some child. And now that child is suffering with some genetic disease. Maybe their heart will become too fatty, or maybe they would develop fats in muscles and so on. There are many, the CFA, the sweat glands, and many other. So sending in something that would go and fix this gene is a gene therapy. It is experimentally done. It is in some cases possible, expensive, difficult, not yet a mainstream thing, but that would be what would be called a gene therapy. And Big Natty, I totally expect even doctors to come out and say, no, the messenger RNA is a gene therapy as well. They would then have to figure out how to work with the definitions of things. So to your question, messenger RNA is not a gene therapy. Now, adenovirus is an interesting case. Adenovirus is a DNA piece that actually goes into the DNA. Over there, it is transcribed into a messenger RNA. That messenger RNA goes out and then works to make the spike protein. That is a gene that is inserted in the DNA, and that functions like a gene. It uses all the enzymes of the gene. It is then destroyed, which normal DNA is not destroyed. So it has some differences, but you could technically call this more easily as a gene therapy, and all the gene therapy process flows and technicalities will apply to it, and it would work with that. But messenger RNA is not a gene therapy. Lizzie, correct. So for some reason, immune response is not modulated, correct. Doug, you actually heard. So he got up now and went. He has become so sticky in this chair. I thought he came back. Baljit Singh says, is it a good idea to start anti-platelet factor 4 Polyanion antibody tests after adeno-based vaccines? Yes, especially for the women under 50 years of age. If one can get a chance of keeping an eye on her clotting state clinically and from labs, it would be great. And I would add, and this is not an advice for anyone because blood thinners can be dangerous, I would add that they should be on blood thinners during this time. Carl says, why is Dr. Mubeen recommending an experimental shot? So Carl, I want to clarify this. I am not recommending. You can watch all the videos since a year. I have always maintained I am fine with the vaccines. I'm a pro-vax. Myself, my family got the vaccine as well. I have never tried to push anyone who is anti-vaccine to say you should go and get vaccine. You would not hear this statement from me for now 15 months. So I'm not recommending. What I'm doing is, it is interesting, people just keep misunderstanding me. What I'm doing is, since 15 months, I have curated and found things that can help with or without vaccine. There were no vaccines 15 months ago. Vaccines started in this November, December timeframe. So never have I recommended. It is your decision. Even if I want to recommend, I actually don't have a place to do that. I'm not an authority in some organization who can say you should take a vaccine. I'm not your doctor. I'm not your family members. And I have been very, very respectful about it. It is funny for me to see that how folks who do not like vaccines, they are usually the ones who insult me all the time. While I have always respected them to say, you take ivermectin, take vitamin D, do other things. Even then, they want me to say that vaccine is bad. I just talked about the vaccines. I am more clear about this vaccine is bad here, and this is how to manage this. So no, I'm not recommending, totally your choice, but I would continue to present what I see. And I agree with this, that sometimes when I present something, I may make a mistake. Those are mine. Mistakes or misinterpretations are mine. They are mostly not deliberate, but some people think it is deliberate, and I find it too useless to spend 15 months to serve a community, people, and then to deliberately misguide and hurt them or harm them. So I just present data. Okay. Keep 1974 says, young man with recent history of multiple pericarditis, messenger RNA vaccine contraindicated. Okay, so the answer has to be seen in this example. People who have heparin-induced thrombocytopenia, or HIT as we call it, they are asked not to take Pfizer-like vaccines, or not Pfizer, sorry, AstraZeneca vaccine or Johnson & Johnson. Not because there is a common mechanism of action, but this person has had this propensity, they might end up in that kind of a state more. This is really just out of not knowing, uncertainty, and fear to protect the person. This decision may be wrong. Similarly, here, out of the protection, I would say that if person who have had pericarditis, they should probably avoid messenger RNA vaccine, especially Pfizer, for which we know, I think that Moderna does it too. Those messenger RNA vaccines which may cause cross-reactivity, just for protection. Do I have the causative data? I have done a lot of searching on this. There are many articles, there are many places that say that there is cardiac inflammation. There is no one yet who has come up to say this is the mechanism. The discussions I have done for the mechanism are general mechanisms for how a virus or a bacteria may cause cardiac damage. So if I am the one, if the patient is my patient, I would try to avoid it. But again, the best is to talk with the doctor. They know the correct history. They know what therapies are being given. Maybe the person has gotten enough medicines and correct medicines that this is not even a consideration. Delina Grag says, I'm definitely pro-vax and cherish Dr. Bean's knowledge and time. Thank you very much. Jude says, runaway spike protein, explain why it was a surprise to the inventors. Good question. So let me explain what will a runaway spike protein mean? So let's start from, here is a cell, and every vaccine is going to do differently. So I'm not talking about Novavax vaccine, because that we still have, it's a different structure, different way to work with it. Let's start with the messenger RNA spike proteins. Adenovirus does that too. Messenger RNA spike protein, for this to do this, the lipid particle has to fuse with the cell membrane, get in there in the cell, open up, release the messenger RNA inside the cell. Then the messenger RNA should make the spike protein with the help of the ribosome. That spike protein should be then loaded, should be broken up and loaded on MHC1 or MHC2, usually MHC2 when it is brought in from outside, then presented, pieces presented outside, and this is how it is digested, it is destroyed. A possibility of the spike protein to come out of the cell could be if this cell is killed and there were some preformed spike proteins that were still going through the process of getting loaded and all that and crushed, they would just come out. And if you do it at a major scale, there may be more, but it should not be a huge issue. But if they come out, so let's say here we have things spilling out of the cell. If that is the case, and there are some spikes sitting here as well, so let's say this is a spike here, ideally the local areas, macrophages, dendritic cells, these things should look at it and eat it up. They should even eat up this virus, this cell as well. So it would be interesting if we said that his spike proteins after a vaccine were produced in such a large quantity that they are everywhere in the body. And this is what some people said to me. They said, hey, you talked about the nanoparticles, and what you've deliberately didn't say is that the nanoparticles or the lipids concentration kept increasing over time. Well, that is how our body works. Our body, when we inject something in our body, for example, ivermectin, we all know about it. When we add ivermectin to our system, ivermectin keep increasing slowly and the peak appears in 6 hours. Then it keeps going down slowly and the half-life is 18 hours. This is how biodistribution works, that you put something in a closed circulatory system and let that cycle in the system. And if there is some tissue attached here, every time the blood is cycling through this, there is some that is given, and then the next cycle and some that is given, and next cycle some that is given. So of course it would increase. And it is not that the particles are now being manufactured somewhere. It is the normal particles that are present and they are running around. Just like if you take ivermectin, it's not that now some part of your body is making ivermectin. It's just slowly circulating through the system and keep increasing. Same here, at least these vaccines, for example, Moderna vaccine does not have an RDRP attached to it. I believe I read about the Oxford's vaccine, AstraZeneca's vaccine. Was it AstraZeneca? No, not Pfizer probably, BioNTech, that it may have a replicator in it, meaning it may have something that would help replicate RNA a little more time. That would mean that they can inject a smaller dose and that dose can increase in the body. Possible with Pfizer, because I remember reading it. Anyways, going back to your question, this is one source of spike protein, but this should not be a large source. Even when the spike proteins come out, these should be eaten up. Now, is it possible that this cell is now presenting spike proteins on its surface? So let's say spike protein RNA is manufactured in a way that it has become a secretory component. So our cells can do secretions as well. So if it is a secretory component, does it secrete or does it just appear on the surface? So let's give it one more idea, that maybe spike protein RNA is structured, engineered in a way that it actually becomes a soluble thing that can come on the surface, but it has a anchoring point to bind it. This is the study we talked about a few days ago. So again, if it is bound here, this spike protein should also not get into the blood or interstitial tissue. Some folks said to me, that this proves Dolores Cahill's point that the spike proteins are now going to be in our cells forever, and they would be present there forever, and the cells are expressing the spike proteins. And then eventually, when the actual virus would appear, our immune system will become active. And when it will become active, it's going to kill all the cells that are expressing the spike protein. And once again, she couldn't be more incorrect here. The reason for that is that this spike protein is not going to be tolerated by the immune system over here. It is not self, it is not part of us. Our immune system cells are not trained to ignore it. And if they learned to ignore it, which is called energy or tolerance, immune tolerance, if they learn to ignore it, and now I have to understand what is the spelling, tolerance, hopefully these are the spellings, then they would ignore it forever. It is not that today I would tolerate it and tomorrow I'll wake up and say I'm upset about it. Although the immune system does do these things with allergies, but not here. So either it would become energetic and ignore it. If that is the case, when the virus would arrive, it is going to become energetic to that as well. That would be bad. But immune system is not going to leave it alone. Immune system is going to dock here. Let's say that there is a spike protein out here or a piece of spike proteins. Immune system is going to dock here, become active, and try to kill the cell. So the cell doesn't become killed when the virus would come in. It would be killed right away. And so now there is this concern that will a muscle cell be killed? Yes, it is possible that it can be killed if it is expressing part of spike protein or all of it. Wherever the spike protein is, that would be killed. So that was the question, that are tissues being killed? And the answer is actually two ways to look at that. While we look at what that study says, you can look at the people who got the vaccine and see, are they dying? Cahill had said that people would die by March, April of this year. March, April has come and gone, and even more time has come and gone, and more people have been vaccinated and they're there. This does not mean that vaccines don't have side effects. This also do not mean that I am asking someone to go take a vaccine and I'm pleading here and begging here. No, I'm not doing that. Totally your call. I am explaining the mechanisms. So the surprise would be, so let's say if I am there, for me the surprise will be that, hey, you know what, this cell got converted into making spike proteins, just like B cells make antibodies and secrete it out there. And for that, we did a studies discussion last week or a couple of weeks ago, where we saw that the spike protein, the researchers who are not doctors, they are geneticists, they thought that the spike protein can release from the cell if the anchor is missing. And I thought about it. I've been a software engineer as well. And yes, if you ask a software engineer that, can you write code that would do this? And they'll say, yeah. Or I can pick up somebody's code and I can say, I can make this tweak to it and it would now do this. So they were thinking from a genetic material coding point of view to say, we can think that the anchor part of the spike protein can be removed and still the rest of the spike protein will be there and that can be released out. Then when they were challenged, they said, hey, we think that we should think in these terms as well, but we are not sure and more data is needed and so on. So they didn't say that this is what is observed in people. They said, we think it can happen. We have seen it in a lab experiment. We can reproduce it in that way. But when they were challenged that our body is not one cell with the lab environment around it, our body is a very sophisticated management system. So this is why it would be a surprise. I do not think that this is a surprise for people who are making vaccines. Other folks who are coming up and saying, I am this guru or inventor and I am surprised, they are just surprised. So that means they have a reason to be surprised and they should explain it. I cannot explain that. This is a fair thing. For example, the studies from Pfizer, and I'm sure there are going to be studies from Moderna and others as well, where newer vaccines, it is interesting to see how are they behaving. What are their dynamics? For example, for ivermectin, we know the dynamics: 6 hours peak, 18 hours half-life. There is biodistribution, let's say, in fats. What are the dynamics of the nanoparticles? It's a fair thing to ask. What is the dynamic of the messenger RNA? You said we'll make the messenger RNA durable. How durable? How long would it stay in the cell? 1 day, 2 days, 10 days? Normally, a messenger RNA is destroyed in 2 days. Would this be longer than that? And if they engineered it to be longer, can we do the research to see if it is really longer? So because of these newer things, it is a fair thing to say we're going to do some research on it. So unfortunately, things are said, every single thing is presented as a huge issue, that the actual truth is somewhere muddied up as well. Savage J says, not really a question. Dr. Mubeen has been very fair on the matter. He's not a propagandist. I have not. And I have always said, I may make a mistake. That may be my issue with interpreting or presenting or articulating. My mistake is my mistake. If you look at my videos for 15 months, I have repeated this message many times that I might make a mistake, and that is mine. That doesn't mean what authors are saying is wrong, or they have an agenda. Many authors do have an agenda. And this is kind of crazy to say, I'm afraid. If I was afraid of any group, vaccine group or anti-vaccine group, or some Republicans or Democrats or person X or person Y, I would have stopped doing these things. I'm not afraid in that way. Okay, so Black Starry Sky says, just joined, but didn't Novavax show bad efficacy against SA variant months ago? I remember 51% or so. Thanks for the great content. Very good question. So I had that thing in my mind as well. Novavax's discussion, they said that during the time we did the trial, the predominant was UK variant or B117 or alpha, and we were very good against that. To me, it seemed like they were trying to say, we don't have data for you for the other variant, so we don't want to show it yet. But eventually they'll have to show that data. So we'll see. My opinion is that they will be fine. Mr. J says, how can anyone truly test for reinfection if their positive test could be from the previous infection, besides genomic sequencing, assuming same mutations both times? Yeah, so you're correct. How do we tell? And so T cell, B cell, RT-PCR at the time of infection, I think that more and more lab works would start appearing, but you're correct for the confusion on this. Big Natty Brub says, would natural immunity be any more effective against variants than immunity achieving through vaccines? Not even variant, even against the original virus. I just uploaded that video yesterday that I had recorded a couple of weeks ago. I recorded that video with the video that was 32 questions about ivermectin. The same night, till 2 or 3 in the morning, I recorded 3 talks. I remember it was a long weekend and I had taken a weekend off and I became bored and I started working on it. People started, when I uploaded it last night, they said, so you became so afraid that now you're saying that the vaccines should not be taken if you have natural infection. And I have been saying this from ever. And I recorded that video 2 weeks ago. So I think folks would continue to say what they want to. Generally, the natural infection would, if you came out, I keep using this word healthy way. I think it would become my my moniker, healthy way. By healthy way, what I mean is without getting a cytokine storm, without getting too much damage by the immune system's response to a virus. If we got the virus, infected, recovered from it, then our immunity is good enough. when can that immunity be bad? That immunity could be bad if our immune system status changes. We become diabetic and uncontrolled. We develop a cancer, we develop a leukemia, we develop HIV, we get an organ transplant, and now we got chemotherapies, or we got immunosuppressions, we got cancer and got chemotherapies. So there are many things that can happen which could then alter our immune system status. But if we came out without those things, if we came out healthy with the fighting with the virus, then we are good. And similarly, if the virus changes too much that neither vaccine nor our immune system can do anything about it, then we are out of the options with the current protection. But I don't see those. If people can become sick, I don't see yet our immune systems to give up that much. And I have done this discussion in the past as well. I'm saying it again. Just like SARS-CoV-2 is a new virus for our body, and our body learned to handle it. If the SARS-CoV-2 becomes SARS-CoV-3, our body will have to learn to handle it. It's not that it's going to say, I think this was SARS-CoV-2. It is so unfair that it has now become SARS-CoV-3. I am not going to mount an immune response anymore. That I don't think our immune system is going to do. Yes, if it becomes SARS-CoV-3, the virus, will have a pandemic all over again. And that is the problem. That means we'll have to lock down again. That means people will have to get infected again, and they'll be damaged again. So that's the problem. Our immune system, it can handle infections. It is built for doing those things. In case of, again, I never have recommended COVID infection because it has propensity to cause long hauling. It has propensity to kill people. So it's not a recommendable natural infection to have. Maria Regina Firmino Castillo, thank you for the super chat. How can one mitigate any potential harm from the available vaccines against COVID-19, from adenovirus to Mrna to inactivated virus, asking for vaccinated family members? Yeah, so there is so look, I'll give you my family's example. 4 members, we have 2 sons and myself and my wife. I got Moderna. One of my sons got Moderna. He's still waiting for his next shot. One of my sons got Pfizer, and my wife got Johnson & Johnson. The 3 men, messenger RNA vaccines, we got nothing. I felt sleepy and frozen, but didn't have much issues. My sons even have lesser issues. My wife, when she got the vaccine, she didn't develop too many of the side effects, but slowly afterwards, I believe as the antibodies kept becoming more and more, there were more side effects, which she is still handling. I think that she has much better situation at this time compared to 2 weeks ago and 3 weeks ago and 4 weeks ago. So now if I look at your question, how do you mitigate potential harm? So I don't feel that I need to mitigate or my sons need to mitigate because after the vaccine, there were no side effects. There is an immediate time after the vaccine dose where possibility of clotting or possibility of myocardial inflammation or other such side effects may be possible. And for that, for clotting, we have to take care of the clotting by the blood thinners. And for possibility of the cardiac inflammation, we have to start either administering anti-inflammatory plus antibodies, so maybe steroids. It really has to be seen that the patient is going to make their antibodies as well. You give steroid and now you suppress everything. So they have to be very keenly observed. And for inactivated viruses, I do not know what is the right thing to do. But for adenovirus and Mrna, these are the kind of things. Then in some people's cases, they develop tinnitus, they have developed neurological adverse reactions. Some people have developed long haul-like symptoms. Some people have developed musculoskeletal issues, chronic GIT issues, and then the management has to be accordingly. Super Knight 1010 says, have you heard of the monkeypox virus? What's it all about? Not yet. So apologies. I was this last 5-10 days busy with my colleague to get her back on her feet, then coming back, getting back in, then having a little back and forth with Luffy, working with the guests and doing this long haul discussion. Then this whole spike protein and the spike protein related topics that continue to pop up, lots of reading. So I was not able to. So Jesse Alvarez says, does having long COVID is inadequate immune reaction? No, I would say dysregulated immune reaction. Inadequate gives an idea of reduced sufficiency. And then if we say overreaction, that gives an idea of more activity. Dysregulated means incorrect response. So the long hauling is an incorrect response. So that is dysregulation. Maximus says, if one has very strong adverse reaction to vaccine antibodies, spike, strong fever, headache, pain, does it mean he would have had strong adverse reaction to virus due to overactive immune system? So Maximus, this is a very interesting question, and I think about that almost every day, that folks who develop more severer symptoms from a vaccine, were they going to get cytokine storms from the virus? And there are two further thoughts. One thought I think is there is no guarantee. So we cannot map it, but it seems like that. And the second part is that vaccine side effects are not sometimes just because of the spike protein. These may be the adjuvants of the vaccines, or maybe vaccine spike protein. So if these are adjuvants, then of course they would not probably do this to the actual virus. But very good question. And I don't have a good answer other than thinking about it and thinking about the mechanisms in my head. B.A. Humdinger says, was sending Mrs. Bean for J&J vaccine a mistake? So some people have gotten much worse adverse reactions than what she has gotten. And fortunately, she continues to become better. I'm seeing nowadays that she is participating in her life much more. She's able to be she's more active, she's more herself compared to before. But there are people who have worst. The question is, who is going to get it? That's the problem. I just generally think women under 50, that should have included my wife, should not take adenovirus-based vaccine. Dr. Amir Hashmi says, sir, my lots of patients doing good after COVID-19. Thank God and Dr. Mubeen sir, who teach me more than glasses advice. You're very welcome. I'm happy that you and your patients are doing well. It is you as a doctor as well. So you're learning and bringing them health. And so that is your part. Genesis Lights says, ivermectin plus fluvoxamine or monoclonal antibodies. So you're talking about active infection. If it is active infection, I'll give both. Ivermectin, fluvoxamine plus the monoclonal antibodies. It should not be, or I would actually say polyclonal antibodies, Regeneron, which is 2. So meaning bring in all the weapons. Don't relent. Don't sit back. Don't be less aggressive. This virus should not be given a chance to expand in our systems. Maria says, is this the same question or is this a follow-up? So this is a follow-up question. So once again, thank you for the super chat. I wonder if ivermectin would be a good prophylactic for negative and serious effects of the vaccine, for example, right after the vaccine or between each doses. So you would probably hear this on this Wednesday as well. So folks are asking all those questions before FLCCC would become upset with me. Yes, steroids and ivermectin is the eventual final prescription. Fluvoxamine may be needed in case of neurological symptoms. Antihistamines may be needed when there is a problem with the MCAS. But this is the general idea. So I feel so happy that without knowing a lot of underneath pathologies, I had been practicing these things and helping patients without any issues. I practice hydroxy, I practice ivermectin, I practice steroid usage, I practiced ivermectin usage. So I feel I lucked out that this happened. So yes, your question is correct. So Tuber Sterini says, do all hospitals prescribe Regeneron? So there is a very important thing, Tuber. Hospitals will not offer you a Regeneron until you ask for it. So because FDA has it authorized on their site, you have a chance to ask for it. But if you don't ask for it, they are not going to ask you. Majority of the hospitals, there may be some exceptions, but you have to ask for it. So I keep saying very often to people, please ask for it. Mr. J says, can I take all of the vaccines with enough time between each dose? Why or why not? Very good question. So the thing to define here will be enough time. For example, it is seen from the previous viruses that the B cell responses decline in the second year and then go down by the end of third year. T cell continue for a long time. So if you said, hey, I'm going to take messenger RNA now, and then I want to have one more vaccine, just as you asked this question. So I would say, yeah, 3 years later or in the third year, maybe you want to have another vaccine. That's one possibility. The second possibility is if you said, I'm not too comfortable with the antibody-based vaccine, spike-based vaccine. I'm afraid of ADE, which is a theoretical mechanism, but let's say people keep talking about it and you become nervous and you say, I'm going to get ADE. So I want inactivated virus as well, so my body can make antibodies to more parts of the virus. Sure. Give enough time that your body doesn't just keep overreacting. So I would not take it within 2 weeks of the previous vaccine. Third part of the answer, you saw that UK did the study of mixing the vaccines, and they saw that the second vaccine, if it was different, could cause more side effects. So again, yes, can be done, but be careful with the side effects. Otherwise, having multiple doses of a vaccine is like multiple infections. And this pandemic is going to make us be exposed to the virus again and again till it is gone. So the vaccine would be similar. The other thing with the vaccines that I had been saying in the beginning is that there are certain vaccines that not only just the mechanism are the concerns or food for thought, there are the way the vaccines are built. For example, some folks do not want to have a vaccine that may be built in a clone of a aborted fetal cell. So in that case, maybe you can mix it, but you would say, hey, I don't want to have a vaccine of this kind. So there are multiple ways to look at this question, but good question, philosophical question. Savage J says, wanted Novavax, but just couldn't wait any longer, unfortunately. Yeah, other vaccines are good too. Mr. J says, thanks, Dr. Bean. Canada has allowed mixing, I think, due to AstraZeneca issues. And this is a smart thing. I think US should do this as well. US should have done it right in the beginning when this issue occurred. Instead, I was embarrassed that our CDC or whatever FDA meeting occurred, and they came back and they said, no, all good. And when they said, at least say no for the women under 50, they said it would be hard to explain, so we would let it go. And then they had said, we'll come back with a protocol for how to manage this kind of a situation. And I never heard of it. Maybe they made a small email and sent it to a few people. Cool Tune says, I'm not vaccinated. Am I a threat to a vaccinated person? No. No. So Genesis says, do you know what's going on with India? They pulled ivermectin protocol, but I'm not seeing what they replaced it with. I was actually looking at some of the messaging from India, and they said, no, we have not pulled it. So it looks like there is some truth and some rumor. I have to do some more research, but what I learned was that they still have ivermectin. Kirsten Dior says, how long can I take ivermectin tablet for a long haul, rapid heart and tightness in chest? I'm on day 5, taking up to 30 milligram per day based on weight. Okay, so ideally, so it is in theory, I'm not advising you. In theory, after taking for 4 or 5 days, one should change it to weekly, not quit it altogether. And then if the situation is still that way, then macrophage activation, mast cell activation, and the steroids-based therapy should be done. So steroid should be the first one to be tried after this, and then a combination with fluvoxamine, with antihistamines, and so on. But the first thing to do would be steroid. If I was managing. So Doug, I believe that there are some parts that are not using it, and then there are some parts that are using it. I do not think that overall India has banned it. So I'll look some more. Eric says, Dr. Robert Malone suggests that Moderna is worse than Pfizer due to higher dose. Is this true? Worst for what? Side effects, damage. Does he also believe, and I've not talked with him, does he also believe that there is a, like Kahil says, mutation in the system? Or does he feel that the messenger RNA would just go into the cells? And so I don't know what his point of view is. I'll have to check it out. But dose more or less, I say it many times, I'll say it once more. Here is your virus. Here is a virus in this cell. This is a virus. It is going to release messenger RNA, which will make a big polyprotein, which will have 3 main enzymes, or 2 main enzymes that would break off from it, 3 chymotrypsin-like enzyme, or MPRO, and the, what is the other one, RDRP. They will come off. They will then help make more messenger RNA copies, because every single daughter that is going to be formed, and there are going to be millions of daughters formed every few hours, and they have to inject new messenger RNA, the viruses mRNA in them. So mRNAs will be made by tons in the infected cells. And not only this, that the whole mRNA is copied. And again, what I'm talking here is something that can be seen in the literature. I'm not going to talk about, I think this is this way because I am a doctor and I said so. This messenger RNA is not only just the complement RNA that is DNA made and then the messenger RNA made to inject as a brain in the new daughter cells. There are pieces of the RNA that would be formed. Some pieces are going to be this long, and some are this long, and some are this long, which would make local enzymes in the cell that would help build more viruses. These RNAs are inside the cell. They are making the viruses. The cell is dying not because there is RNA. The cell is dying because their machinery is hijacked. by the proteins made by the RNA. So now, if I go back to your question, Moderna or Pfizer, tiny bits of RNA, micrograms of RNA, or micrograms. Compare that to the virus-injected RNA or virus-created RNA. So we are now comparing Pfizer and Moderna and say that is 2 microgram and this is 5 microgram. Do you know why Moderna's dose is more and Pfizer's dose is less? And this again is this open public information. Look it up. Pfizer said our dose is low. We can make from 1 bucket. I remember their statement. This was Oxford, that with 1 bucket we can make this many 100 million vaccine doses, because their vaccine had a replicator with it. So when the messenger RNA gets into the cell, then it is replicated a little more. And Pfizer said, at that time, Oxford said that this way it is cost effective because we don't have to create drums of RNA outside. We can give tiny amounts and those would then replicate inside and make more RNAs. Moderna does not have that technology. Moderna, you have to give the dose from outside. And Oxford actually kind of criticized Moderna in a healthy way that, hey, they need to give a larger dose and we can give a smaller dose because a dose would expand inside. Did someone bring that? And this is in Oxford papers. And I have talked about it. So if you go about a year ago and look at Oxford BioNTech video, I have talked about it. And most of the time I show the paper as well. I'm talking about it. So you may be able to see that too. So I don't see that there is a dose difference eventually. Cool Tune says, thank you, Drbeen. You're very welcome. So it is 8:22. Let's break for today. There are so many other questions. We will continue. Let's break. Please remember that Wednesday I might not come online because I may be with the FLCCC. If I come back early enough, I would be online as well. We'll continue tomorrow. Please like, subscribe, and share. And please, if you wanted to support this work, if you would like to support this work, there are 3 links in the description. You can buy me a coffee, or you can use PayPal to support this work, or you can be a patron. So thank you very much, and I would see you tomorrow.